Welcome to today's webinar on Whole Health, Whole Mothers, Lessons from the WHO Special Initiative on Integrating Maternal Mental Health Care. We'll just give it a few minutes as people are joining. And as people are joining, just a few reminders. You could use the chat to introduce yourself, but for any questions, feel free to use the Q&A section. So just use the Q&A section for any questions you may have, and they'll be answered as we go along. And I'll hand over to Aisha.
Brilliant. Thank you so much, Joy. So welcome, everyone. My name is Aisha Malik. I'm a mental health specialist at the World Health Organization, and I'm going to be your moderator today. I work as part of the Special Initiative team, focusing previously on supporting the Philippines and now working with Cambodia. I may be a new face to many of you, as you're usually used to seeing Alison Schaefer, who is the lead for Special Initiative, in these webinars. But unfortunately, Ali is traveling today, so she's not able to moderate the session, but we hope she's dialing in to listen in. So as you know, we have these Special Initiative learning webinars because we want to actually disseminate and share what are we actually learning as part of the Special Initiative work that we're conducting across the 10 countries. And this is the work that's really done to transform the gap that we see in mental health services and care. And today's topic really focuses on what we see as a key issue of maternal mental health, because becoming and being pregnant and the postpartum period takes a tremendous toll on the bodies of people born female. And that's even before we take into account other adversities that can impact our mental health depending on where we live, such as difficulties in the environment, poverty, physical violence, and so on. So experiencing changes to mental health during this perinatal period is very common. Now, the principal point of contact for women and infants is typically maternal and child health services. And these services are usually far more advanced than mental health programs in many special initiative countries. So working to integrate the identification of mental health needs and provide support through these services is, we believe, a strong strategic approach to expanding access to mental health care. And this integration is also likely to be more cost-effective and more sustainable because maternal and child health services are usually better funded than mental health services. Now, in the context of special initiative, we know that many special initiative country governments have prioritized maternal mental health, and that includes Nepal and Jordan, who are here to present to us today as part of the webinar agenda. So we're going to hear from our colleagues in Nepal, we're going to hear from our colleagues in Jordan, and we're also going to hear from one of our experts here at headquarters on the area of maternal mental health. I'd also like to introduce to you my colleagues from WHO, Lydia and Giovanni, who are going to be monitoring the chat and the Q&A. So we would like you to actively use the chat during this webinar. Maybe you'd like to introduce yourselves or share what work you're doing in the area of maternal mental health or any issues or challenges you've seen in this area. And then when you listen to our speakers, please do use the Q&A so that we have some questions ready for them. What I'll do now is introduce our first speaker, who is Dr. Kedar Marahata, who is from our WHO National Professional Officer for Mental Health in the WHO Country Office of Nepal. Now, Kedar is a psychiatrist by background, and he oversees the country implementation of WHO's Special Initiative for Mental Health in Nepal. And as part of this work, Kedar has been working to ensure a stronger presence of mental health services in Nepal's maternal and child health services, and that includes in Nepal's National Maternity Hospital. So thanks for being with us, Kedar, and over to you to share your work in this area in Nepal.
Thank you so much, Aisa. I hope you can hear me well.
Yes, we hear you.
Okay, yeah, thank you. Thank you for having me. And pleased to be joining this webinar. I'll be sharing with Nepal's experience on attempting to integrate mental health into a maternal health program. Nepal is one of the low resource country attempting to improve with limited resources the life of people. And then mental health is not a top priority for Ministry of Health. And then we are trying to, with special initiative support, we're trying to prioritize mental health. And with this program, maternal mental health is one of our newer and emerging work stream here in the country. So can you, next slide, please. So when we look at the numbers, the first one here shows historically a country has progressed quite a lot in terms of reducing deaths among mothers. It's on track to meet probably the SDG goal, reducing deaths. On the other side, it is possible because of improving the quality of maternal health care, including through the deliveries conducted by skilled birth attendants, where more than 80% do so. So while things on reducing deaths is improving, but what country did last year is review all maternal deaths, the cause of all maternal deaths, and they found that 6% of total maternal deaths are due to self-harm. When countries progress in reducing preventable deaths, then the causes such as self-harm comes, and then the proportionately it contributes substantial proportion of deaths. So that became the entry point for us to advocate for a stronger maternal mental health program in the country. And country is also preparing from traditional 4 antenatal checkup visits to 8 antenatal checkup visits, and then similarly increasing to 4 postnatal checkups. So this then gives them more opportunity for mother interacting with health, and then more opportunity to also work on mental health. Next slide, please. So it took a while for us to set this agenda for maternal health team. It was kind of considered as, mostly based on our experience, maternal health program considered this as a mental health program's need, and all they can probably do is refer to mental health program, wherein all interventions should happen in the mental health program. And as I said, mental health program is not a priority and is rather weak and is not in position to do so. So it took a while for us actually to advocate that it is a part of a whole, at the topic of today's webinar, the mother's health. And then getting some convincing to do, but finally we've been able to set this up as an agenda in maternal health program, and then a country developed integration framework. The one in Nepali script here says Amako Man Karyakram, which translates as Mother's Mind program, which mother's kind of more emotional mind than thought mind, I'd rather say. So we named it as that to attract, to reduce stigmatizing name, and also attract more relevance to the program. So with that, with the aspiration to provide mental health education to all pregnant mothers, irrespective of the need, and then prioritizing stress management to those with high risk mothers in earliest possible time, and then instigating a practice of, let's say, checking for mood, worry, self-harm during antenatal checkup, and equipping maternal health providers with some skills on providing psychosocial services. So with this, we developed a national integration framework, which is under endorsement by Ministry of Health and Population. But at the same time, the program during that time, it was not a priority right from the primary care to specialized care. Even in the biggest maternity hospital in the country, mental health was not there. So we also then prioritized that, targeted that hospital, and prepared a standard operating, next slide, you can click next slide, procedure to integrate this. So with this, And then, we discuss again with the hospital. A lot of advocacy needed to be there. The hospital is overcrowded, like having to attend 600 antenatal checkups per day. So it's a very, very busy hospital. There are no space available. Nobody has a time to talk about mental health. And then 3 or 4 physicians used to share space for antenatal desks. So it's like overcrowded with families, friends, and talking sensitive issues such as suicide, self-harm, and depression become like almost impossible. But then we kind of nudge this, and then we were given a corner, storage, rather dark corner, and then we utilize the space. You can see the picture where I'm there discussing with the vendor construction guys which carpet to use on the floor, and then having a minister inaugurate last year in October 2 mental health professional posted there, and you can see the postnatal mothers being given some relaxation and mental health education session. So this is quite a win for us in establishing the care in that hospital. Next slide, please. But at the same time, we are also prioritizing primary care level, and then done a pre-pilot of integration framework in 2 districts, primary care centers, birthing centers, and others. And we have now planned for this year to pilot in 2 sites. So having said that, we are at the initial stage of implementing this. There are a couple of challenges and choices that we had to make. Like, for example, which conditions are a priority. Oftentimes when you say mental health, people feel that's one condition, right? But then within mental health, there are so many conditions, and then it requires different tools to screen. And then, when you go into this, it complicates the matter. And then people say, oh, no, it's not possible kind of situation. So very common depression, anxiety, alcohol use, drug use, tobacco, psychosis, self-harm. There are a number of conditions which are highly relevant during pregnancy and postpartum periods. We had to kind of prioritize against the resources. And then the screening part of it. Our healthcare, as I said, like 600 ANC in a crowded room, and giving a printed tool on screen. And then if we prioritize a few more conditions, then a few more tools, is then again another barrier that we had to kind of decide. Is a screening tool fit to clinical care? How long it will take? Even if somebody screened, how is the information be kind of used? Versus if we want to train with some practical question, then would it be like sensitive enough or specific to detect care? So it was a challenging choice. And then towards the end, then recording and reporting became another challenge for us, because maternal mental health is not a diagnosis. For a mental health perspective, it's a depression, it's anxiety for an adult male or a postpartum mother. And then when we record in mental health program, then we lose the postpartum period. Then it becomes a general ocean of mental health condition. To the most we can identify women of this age having depression. When we then attempt to include into maternal health register, then there are also the challenges of then this diagnosis, the ICD and all that comes in. So these were, next slide, if you could click the next slide. So we had to navigate some of these challenges despite increasing evidence around integration. So what we end up doing is we dropped quite a few condition. We focused on maybe depression is the one, anxiety is the another one, self-harm is 3 conditions that we can check during ANC regularly, whereas psychosis, there are a lot of feedback that most likely it's obvious. We probably do not need a screening question, but then educate our providers to detect psychosis mostly during postpartum period. So that's where the assumption came in. And when we prioritize these 4 conditions, we dropped alcohol, despite it's important, despite it's prevalent, we are in the first phase. And drug and tobacco is dropped. And then we, rather than going for screening questions, 3 or 4, we thought probably we want to include some practical questions with 3. One to check mood, 2 second on stress, indicating anxiety, and 3rd one is self-harm. So we have devised a question in Nepali. We have not evaluated this question, but we're hoping that When a provider checks whether your baby is moving, are you taking good care of yourself? How is your mood? Are you worried, or are you thinking about self-harm? As simple as that. So it's simplistic, we know, but I think that's the best possible opener for conversation around mood and stress level and self-harm. We are very, let's say, enthusiastic to ask in all ANC visits on 3 questions, and but at least twice during ANC and once during postnatal. That too, we have not been able. Is at least in the let's say development phase. We have agreed that this is probably a good one, and then we kind of in a pilot phase want to have a separate register. We ended up putting it a separate register at this stage, but going forward we'll need to discuss. We are discussing whether we could, let's say, indicate in maternal health register, refer for mental health, and then mental health register, refer in from maternal health, and then register the details, so that we will deep dive and probably be able to identify. So these were some of the thought processes we went through. Next, please. So yeah, this is very summary, and then patients is, I think it took us 2 years to set up an agenda and then come this far. In public health, experienced colleague taught me that takes a long time to go forward, but it requires a lot of patience from our side. And mental health is often considered by maternal health program as a specialist, and we want to refer, but we can't do much. There are certain things that even the maternal health team can do something, required quite a bit of a convincing. And then we have a range of services from overcrowding to in primary care 4 ANC per month. So, even the one size doesn't fit, even in a country like ours, where primary care midwife have longer time even to administer some of the tool, versus bigger hospital doesn't have time. So I think we require kind of very tailored approach even within the country. And then mental health is not recognized by the women's, and then stigma and ill-resourced mental health program to be able to absorb the referral. If in optimistic situation it works very well and we get a lot of referral, then mental health program is rather developing. So these were some of the thoughts that I thought I would share, and I'd love to hear if you have any questions or feedback going forward. Yeah, back to you, Asa. Thank you.
Thank you so much, Kedar. It was amazing to hear about what felt like a big story of advocacy pushing, working with colleagues in the maternal health services. And it's interesting because we do live in a world where physical health is important and where mortality rates are in our SDGs and the things that we prioritize. And it sounds like there was a two-part story here for me. The first was, well, you're working with colleagues they're very busy. You're saying 600 checkups per day. There's no space or privacy to have conversations on mental health, and their priority is the physical well-being of the women that are attending this hospital. So I would like to know, how did you even get to you kept dropping hints. How did you convince them that, look, even at the minimum, we should be asking about these 4 priority conditions? That's my first part. And then my second part is, I know you want to have these screenings done at more than those 3 appointments. So you said right now screening is taking place in 2 antenatal, 1 postnatal appointment. Can you imagine a time in the future where you will be able to add the questions more regularly to the appointments? Over to you, because I'm sure there's many other colleagues on the call in this position that want to know, how did you make that advocacy work? Thanks, Kedar.
Yeah, thank you. It required quite a bit of a pushing from yeah, it is not possible. Can I discuss an initial conversation where it is impossible? But we kept on going and discussing. To what we then planned is organize seminars to all staff where nurses are welcome, doctors are welcome, kind of 1.5 hour lunchtime seminar where we present such topics on depression from their perspective. Why managing depression is important from maternal health perspective. Forget about providing mental health care. You provide maternal health care. Even then, depression is important for child health, for mother's health, for ANC checkup, for example. You aim to achieve 80% and you want to improve more, then probably you should address depression. For reduction maternal health, we have done so far, but going forward will require, talk around self-harm. So these were presenting from their angle was something that we did, and we organized like all staff. We covered around 300 hospital staffs in a few months' time on such discussions. This is one. Two is few of the hospital nurses who would provide gender services, violence and gender and other services were counselor nurse. So we also use their presence to convince the authority that it is important concern. And third is also some of the personal issues. We found some of the physician having living with a family having mental health problem, and then having to how difficult it is to refer from one hospital to another hospital to provide care. So I think we used kind of multiple approaches to convince finally to set up a care in that hospital who said it is impossible. It is still difficult there. But yeah, this is something that we did here.
No, that's brilliant, and I really like I like all of the strategy that you suggested, and the fact that it took multiple different approaches, and in particular the time that you took to do the webinars for the medical staff and really selling that point that we're aware of, and which is why we need more evidence for it, that if you improve mental health outcomes, it will improve the relevant physical health outcomes that our medical colleagues are working on as well. Yeah. Thank you so much, Kedar. Colleagues, if you have any questions for Kedar, please put them in the Q&A or in the chat, and we will hopefully have some time at the end if you've got any further follow-up questions about the work that's been presented in Nepal. Otherwise, I'm going to, in the meantime, introduce our next speaker, who is Hadil Alfar, who is WHO's National Professional Officer in Jordan. Now, Hadil's a psychologist, and she's leading on the special initiative work in Jordan. And she's also been focusing on increasing access to quality services for women who've been experiencing maternal mental health challenges. And it's especially focused on the integration of these services at primary healthcare level. So over to you, Hadil, to share more about the work in Jordan.
Thank you so much. Hello, everyone. Hello, everyone, and thank you so much for the opportunity to be with you today and to join you in this important webinar and share with you some snapshots from our journey with supporting maternal mental health and integrating mental health at all the healthcare levels. Just before I start my presentation, I just want to say really thank you to Kedar for his impressive, presentation. It's a true inspiration, and I couldn't agree with you more, Kedar, on the patience thing. So I know it's very important, and we need to have patience in our work moving forward. So thank you so much. Okay, so next slide, please. Everybody knows why we need maternal mental health. Everybody knows about the common conditions of depression, anxiety. They go unnoticed, they go under-identified due to the stigma, which I think all of us globally share, but it's even more here in Jordan. Jordan, by the way, it's a middle-income country in the Middle East. It's a conservative country. Stigma and social barriers are very much, you can see it clearly here in the country. And unfortunately, we have been affected by protracted emergencies and conflicts surrounding us for so many years, which while might be an opportunity to scale up mental health services, but yet it's a burden, and it keeps, sometimes shifting priorities and posing some competition on what needs to be on the health agenda. So we're trying very hard to keep mental health always on the agenda. Here I'm just sharing our guidance. We have the National Mental Health and Substance Use Action Plan. This is the recent one, and this is the framework for our implementation in the country. This plan is guided by the Global Mental Health Action Plan. It is guided by the regional framework on scaling up action on mental health. And most importantly, it has been drafted while guided by the vision of the Special Initiative for Mental Health. So we share the vision and the direction of the Special Initiative within this National Action Plan. We believe that mental health matters just as much for women, just as much as their physical health matter. So we're trying our best to reshape our system to reflect that. Next slide, please. Okay. So what did we do? We have the policy, and we moved towards the direction of transferring and transforming this policy guidance into practice. Our implementation framework is guided again by the Special Initiative. We have aligned our intervention with the WHO guidance on perinatal and maternal mental health integration, and we have expanded on our image gap and thinking healthy packages. For those who are not familiar with those, but these are the WHO flagship evidence-based packages on integrating mental health and maternal mental health into primary health care towards scaling up the postpartum depression screening and pacing intervention in maternal clinics. As of today, we have an estimated over 1,000 workers trained, which is 20% of all of the health workers operating in Jordan. And we have covered about 41% of the primary healthcare centers operating in Jordan. So this is a very good, achievement that we are all proud of. And MOH, the Ministry of Health, have integrated these packages within their health, strategy. So we're not only talking about the mental health specific action plan, but we're also talking about the overall umbrella. And another milestone was when the image gap was incorporated within the Ministry of Health Family Physicians Pre-Service Training Program since 2022. WHO is providing the technical support, and what we are trying to do with all of our implementation, whether with the Ministry of Health, but also with our health partners, it's not a side project. It needs to be recognized, structured, and to be part of national care delivery. Next slide, please. All right, I'll just take you now through some of the main key initiatives on perinatal depression in particular, which were led by the Ministry of Health and the Royal Medical Services, the two main health providers in the kingdom. Just to mention them briefly, we have developed guidelines based on the WHO Thinking Healthy guidelines and WHO other guideline into. We have developed actually two guidelines, just to be specific. One is for healthcare providers, and the other one is for community health workers. Mental health counseling integrated into maternal health file. Postnatal depression screening indicator added to the monthly mother and child health reports for tracking. Mental health and perinatal depression included in the integrated counseling guide under the quality component. So now it is part of the quality checklist. A DEMPRA postnatal depression scale was officially adopted, health workers were trained on it, and it is integrated into the Women's Health File for routine antenatal and postnatal visits. And this is all aimed to reduce stigma and enable early detection and support timely intervention and referral to specialists when needed. The referral pathways were established, internal and external referrals created within the primary healthcare level, and a special focus on training family doctors to address mental health care gaps, because in Jordan we have limited mental health specialists in terms of psychiatrists. So we are relying more on the family physicians. An Excel-based tool was developed to track detected cases and to track the referral. And charts were created to support the providers during the counseling, something like a job aid. Next slide, please. Okay. So I just want to say that all of this wouldn't be possible without the great partnership that we were able to achieve during the implementation. It is powered by the partnership, and I will just mention some key partnerships here, not all of them. The first one was when within the WHO Special Initiative, we were able to develop and launch a WHO MOH investment case for mental health. This effort underscores the economic and social value of scaling up mental health services, including maternal mental health, and it guided resources mobilization and policy planning to strengthen mental health system. Although this unfortunately was later challenged by all the funding gaps and the funding cuts that we were directly affected by, but still it was a great resource mobilization opportunity, and it created a momentum. The next key initiative or partner is the UNICEF Jordan support for integrating maternal and child health services within the national healthcare facilities. The other one is related to the Royal Health Awareness Society work on mental health in schools and communities. They are very active in promoting mental health awareness and early intervention through school and community-based programs. These efforts help destigmatize mental health issues and empower women and families as a whole. So they work from at the community level, and they try to focus on social structures and schools as well. Next slide, please. Here, I would like also to mention the efforts by the Bernard Vallier Foundation with their parenting support and maternal well-being. And also to mention the International Medical Corps, IMC, work as they have been and continue to be a strategic partner in mental health reform. They have played a great role in integrating mental health into existing primary healthcare services. This strategic collaboration contributed to scaling up mental health services across the kingdom. They have also launched an app, a mobile app. It's called Relax. And one of the recent presentation that I have attended by IMC, they have reported that over 800 women reached through this mobile app. 60% of them were referred to clinics for further care. So this is also a great step towards innovation in mental health. Next slide, please. All right. So despite all the great work and all the achievements, we know that there are always challenges, and there were always lessons to learn from. And I will share some from our experience here in Jordan. I'm sure so many other colleagues and the countries share with us these challenges. There is limited integration at the primary care level, despite the policy support and despite the commitment from the Ministry of Health. But actual integration of mental health into routine maternal and child health services yet to be strengthened, especially in rural and under-resourced areas. So we see that there is a great, progress in big cities like Amman, but when it comes to rural and under-resourced areas, this work is not very much, consistent. The second one is related to the capacity gaps among frontline health workers. And some of them, unfortunately, sometimes they lack the confidence or the time to screen for and respond to maternal mental health, even when the capacity or the tool or the protocol is existing in that facility. The third one, the very common one, is the persistent stigma and low awareness. So cultural stigma is something that we cannot deny. It continues to hinder our work, particularly during pregnancy and at postpartum, because this is often looked at as a weakness by the mother. So it continues to deter women from seeking help, even when services exist. Then fragmented service delivery and coordination. There are so many actors, multiple actors are involved, but coordination across sectors and levels of care needs to be more strengthened and ensuring continuity and equality of care. And lack of routine data monitoring. And this is something that we are struggling with, as there is no standardized mechanism to track maternal mental health outcomes or service utilization, limiting our ability to evaluate the impact or guide our planning moving forward. Just before we go to the second slide, I would like to mention that I put this photo on this slide, which is the photo that you can see, is related to one of the new established mental health clinic within a general hospital. I often include such images in my presentation as a reminder, as something to motivate us more of how far we have come so far since the launch of the special initiative. When we started, we had around 52 clinics in Jordan, and now we have about 66 as of today. This is a great increase in coverage, about 25%, and it is something that keeps us moving forward despite the challenges. Next slide, please. So what is the way forward? We need to build on the progress. First, we want to strengthen implementation and supervision at facility level. Supervision is very, very, very key to ensure consistent use of existing tools and referral charts through regular coaching and supervision, especially in high volume clinics and facilities. We need to expand community engagement and awareness, and we need to monitor referral effectiveness, the effectiveness part, not just the numbers. And finally, to integrate mental health into broader quality of care efforts, to link it to more visibly with ongoing quality improvement initiative, whether in maternal and newborn care or others, making it part of high quality care within the national system. Next slide, please. Okay. This is the last slide. I just want to say that we believe that caring for mothers is caring for the future. It's not an investment. It's not just a luxury when we support mental health for women. It is a true investment, and we try to, within our system and within our implementation, to have a combination of systems, people, and partnership. Ensuring that maternal mental health is a cornerstone of care, not just within the special initiative for mental health, but even beyond that. This is my last slide, and I would like to hear from you if you have any reflection or comments. Thank you.
Thank you so much, Hadil. Wow. It is really incredible to hear from both you and Kedar on how Special Initiative has been pushing this work forward. But you just described in Jordan a total multi-layered approach to taking action on integration for maternal mental health. You've described guidelines, policy, capacity building, service delivery, screenings, and what's happening in the community, and even a digital app as well. So my first question, just back to you, is how did Jordan commit so heavily in a multi-layered way to the issue of maternal mental health? Thinking about the advocacy that Kedar was talking about, what happened here in Jordan?
Well, thank you so much, Aisha. This was not done recently. This is like, it is accumulation of efforts that have been done by WHO, the national authorities, and other partners. I admit that it wasn't easy, but we also we appreciated a lot the commitment from the Ministry of Health, despite the limited resources, whether the financial or the human resources. But they have been very collaborative in accepting and collaborating with WHO towards integrating mental health. We know that the most important lesson that we have learned, that no single actor can do this alone. The progress we have made and the way forward, it depends a lot on the continued coordination between the ministry, the UN agencies, the NGOs, and the community level. We have been really fortunate with the involvement of people with lived experience. They have established a service user association, and they have been very vocal, and they have been contributing a lot at so many levels. So I think all of these factors were directed towards the right direction, and we hope that we can continue moving forward. Yeah.
Brilliant, thank you. So and it really makes sense to me why you presented on all the partnerships involved, because it sounds like that's been a huge collective driving force.
Exactly.
Brilliant. Hadil, I actually have one more question for you, if that's okay.
Yeah,
Which is,
please.
you mentioned many different opportunities and health workers when a mother might enter a service for where they might get care. I'm just wondering if you would mind to just quickly walk us through what would happen for a mother if she's accessing support. Who's screening her? Where does she go? Walk us through her journey in, for example, Amman.
Yeah. Listen, she would go to the nearest primary healthcare primary healthcare center. Usually this is the case. So she would access the closest and nearest primary healthcare center. And it's usually the PHC. It's not a special clinic where mental health is written anywhere. And she would see the nurse. So her first encounter is always the nurse. And we rely on the commitment from nurses, and we rely on their support. And this is very, beautiful when you see it from women, from usually women to women, because the majority of nurses here in Jordan are women. So she would be seen by that nurse, and the nurse would then take her to the family physician for checkup or for consultation or the service that she would need. And then if the family physician was trained, supervised on a MIJGAB and other like healthy thinking healthy package, he would know what to do next. But Aisha, like from my experience with our implementation, whether through primary healthcare or even specialist services, at the heart of all of this is actually the woman. So I can see that mothers are usually appreciated in the community. And also the health workers are appreciated, and the community members are appreciated. So I think it plays like there is this bond when it comes to maternal mental health. So they keep their needs at the center, and they continue to listen and adapt. And this is something that I keep saying to our, healthcare workers at the different centers. So you don't necessarily need to know what to do fully. You just need to listen, and you just need to do the referral at the bare minimum.
Wonderful. Thank you. Really powerful story. Appreciate you sharing, Hadil.
Thank you so much.
All right. We've got one more presentation for you. We're going to hear from expert at headquarters, which is my colleague, Dr. Nirja Chowdhury. And she has a presentation which is pre-recorded for us because unfortunately she's not able to join us in person today. So Nirja has led the work that you've heard mentioned today, including our guide for the integration of perinatal mental health in maternal and child health services. And I think Lydia is going to post it in the chat for us. And she was also instrumentally involved in Thinking Healthy as well. So over to Nirja's recorded presentation. So I'm not hearing the sound on my end. I don't know if anyone else is hearing the sound.
No, we are not hearing the sound.
Hello, everyone. Imagine bringing a new life into the world. What should
Now we
be
hear it.
joy and hope? But for 1 in 5 women globally, this period is overshadowed by mental health struggles. In low and middle income countries, the burden is even higher, with depression and anxiety being the most common conditions in this period. The risk of suicide during this period is a very real one. And fathers and other caregivers can also experience mental health conditions during this time. This is a health crisis, and it's one we can no longer afford to ignore. When left unaddressed, these conditions lead to poorer health outcomes with reduced care seeking and increased substance use, for example. Children of mothers with depression are more likely to be underweight, stunted, and face emotional, behavioral, as well as cognitive challenges. The economic cost is substantial, and what is even more disturbing is the human cost, the lost potential, the silent suffering, which are immeasurable. The good news is that treating perinatal mental health conditions improves not only mental and physical health of the woman, but has the potential to improve child health and development outcomes. And we have solutions. WHO is leading bold initiatives to integrate mental health into maternal and child health services. This means meeting women where they already are during antenatal visits, postnatal checkups, as well as community outreach. The WHO guide provides program managers with the know-how to develop and sustain evidence-informed approaches for this, including how to address policies, planning, training and supervision, monitoring and evaluation, as well as financial management. And the interventions can be delivered in a stepped care manner, where basic psychosocial care and support are delivered to all women in the perinatal period, while those who are at risk for depression and anxiety or who have these conditions can be provided further treatment and referral to specialists if needed. We are not starting from scratch. WHO guidelines for early child development as well as postnatal care have specific recommendations for perinatal mental health integration. WHO has developed evidence-based tools like the Thinking Healthy program and MHGAP, which in fact now includes an e-learning course on the WHO Academy. And we are working with countries to adapt and implement these tools. We are focusing also on vulnerable groups, adolescents, women living with HIV, those in humanitarian settings, and those experiencing violence. We have numerous opportunities. What do we now need? We need global leadership to advocate for change. We need regional collaboration to share knowledge and strategies. And we need national commitment to integrate mental health into every layer of maternal health care. WHO is uniquely positioned to convene, coordinate, and catalyze this movement, but we cannot do it alone. We need your voice, your partnership, and your investment. Because when we invest in perinatal mental health, we invest in healthier families, stronger communities, and future generations. Let's act now so that every woman experiences the joy she deserves during this period in her life. Thank you.
Brilliant. Thank you very much, Nirja. And I think some of the resources that Nirja was presenting, I hope are either going to be available in the chat. They're not in the chat. They're also available through our website. So thanks very much again. Due to time, what I'm going to do is move to questions from the audience for our speakers today. So just taking a look at some of your questions here. So I wonder if Kedar and Hadil could be ready. So, okay, I'll ask a question, and I think you should hopefully both have time to answer this one. So maybe we'll first start with Kedar and then to Hadil. So a question that has come in is, our question poser is asking how clinical or specialized services for mental health are linked with community-based psychosocial support services in your settings, such as peer support groups or other types of safe spaces. So how is the work for maternal mental health being organized in a way that people have access to multi-layered support by service users? So over to you first, Kedar.
Yeah, very, very important question and aspect. We are yet to roll out the maternal mental health program integration into primary healthcare level, but we are very cognizant of this fact. So what we are thinking is to use two. One is gender-based services. Gender-based violence prevention and response services is available in the country. So that's the one. Oftentimes, one of the psycho counselor is placed in such services. So that's going to be a very important resource for us. Second is also to use community-based health workers. In Nepal, we have very popular female community health volunteers. They are traditionally set up to assist in maternal and child health services. So we are also targeting those volunteers to also talk about mental health and bring in services, but also link to the resources. even in the mental health program and the community-based services you link, like peer support, others are yet to be developed here in the country. So we do not have established peer support services across the country, but wherever it's available, we will always kind of link to these services. So I will stop at that on this question. Thank you.
Brilliant. See, the problem here is you both keep giving really good responses, and then I want to ask you more questions. So I'll just quickly do a little follow-up, which is you mentioned something very interesting, which was the idea of having, for example, a counselor or a psychologist integrated in with GBV services, which women would also access. Has that approach also been used or suggested for the maternity hospital, for example, to put a psychologist in place in the hospital available for women that are attending the service?
Yes, exactly. That was actually one of the entry to convince the hospital management. The hospital already had gender-based violence services, GBV services, where few nurses were trained as counselors. So they were providing the services, additional support around mental health. They were the internal kind of advocates within the team. So they're active in hospital along with the medical team to provide psychosocial support. So yeah, oftentimes it's very interlinked. Violence happens and then mental health problem happens. So yeah.
Thanks, Kedar. How about you, Hadil? And let me know if you want me to repeat the question.
Yes, Aisha. No, thank you. I think it's clear. So basically, for community for community social support, you mean availability for women? Well, basically, we have two tracks. We have the formal one, which is the actual integration of mental and maternal mental health within the primary healthcare level. So that would be our best chance for a woman to go and during her routine postpartum depression screening, or even before that, that the doctor or the nurse or the GP would detect or would capture this incident, and they would act on it. And there is the unofficial or informal track, which is usually the family support or the modern platforms when it comes to social media, when it comes to peer support, which is actually peer support in Jordan is not institutionalized. So it's not something that the ministry is formally adapting into their health centers, but it is something that usually comes as an initiative by community health workers in certain areas. So we cannot say that this is a general support available for everyone. So in certain areas you would see that some people are more motivated than others to do this initiative for their own community, and then a woman would be able to access this peer support group, or to join a social media kind of program to benefit from. And this is something that we have noticed even more particular with younger generations. I hope I answered your question.
Yes, you did. Thanks very much. We've also got some questions coming in that I think you could both answer. And I know, Kedar, you already mentioned it a little bit in your presentation about, we've got quite a few questions about screening. What are the screening tools that you've used? So Kedar, I don't know if you want to just again summarize the clever approach that you've taken for efficiency purposes, and then over to Hadil.
Sure. Yeah, we had quite a bit of a deliberation around screening, and then as soon as the screening as a tool being presented, there is a lot of anxiety from the maternal health team that having to fill up a long tool. There are, of course, options around few questions tool available, but at the same time, we are also very cognizant about the clinical workflow. In clinics, it doesn't always happen like rating and scoring, right? In clinics, we ask questions and we evaluate and then make decisions. So we kind of trying to devise few clever questions, as I said, to make them less anxious. Check the mood, check worry, and check self-harm, and then we have questions to how to do that, and then we have formal screening tools such as EDPS and other PHQ and others and an annex. So it's really a layered that way approach wherever what is feasible in any clinical setting, but we want to make them like very practical and in clinical orientation, right? When they check where are you taking iron tablets and how is mood like, how is your worry like? This is that kind of approach we are taking. So we're not very sure. We need to evaluate how it works in later date, but that's the approach that we're taking so far.
Fantastic. And who is the health worker that delivers you've got the quick identification questions, and then you've got the more in-depth screening questions. Who's delivering those two things? Is it the same person?
Yes, actually, similar to Jordan, the midwives who does the ANC at the primary care level would be the one who does this opening conversation. So, but then as soon as further suspicion of further support is sought after, then we're trying to build up one medical diagnostic evaluation is done by a medical doctor, a basic medical doctor, whereas another midwife, let's say in a strategic location, would provide more of a sessions, stress management session in line with Thinking Healthy. I'm not very confident whether we will be able to implement the intensive Thinking Healthy either. Just wanted to say that. So we are using in different layers, GPs and medical doctors and the experienced nurse here. Yeah.
Brilliant. Thanks, Keda. Over to you, Hadil, as well on the screening that's taken, the screening approach in Jordan.
Hello. Yes. Okay,
we
good.
hear you.
Yeah. So the main screening tools that have been, used here in Jordan are, I believe, the same main ones that maybe Kedar mentioned. We have the patient health questionnaire, the PHQ-9. It is widely used, especially that it has been validated and it is available in Arabic. So let's keep that in mind because this is the official language in the country. So we always try to, have this in mind. The depression, anxiety, stress scale, and the Edinburgh postnatal depression scale. These are the main and the widely used ones that are validated, adapted into Arabic, have been integrated within the system years and years ago. So everybody kind of feels more confident with. And since also the integration of ImageGap, we tend to see that more nurses and the GPs are more confident using ImageGap at the primary healthcare level. But definitely when it comes to something, and we have noticed that some of them, when they are not very confident, they tend to immediately refer to a psychiatrist. But this is not always the case. But yeah, we have noticed that.
Brilliant. Thank you so much. Looking at the time, I think what we'll do now is we'll wrap up. But thank you to Keda and to Hadil for your great presentations. There are a lot of comments and questions saying how fantastic your presentations are and also how fantastic the work is. So I'm sure there are many more questions to come your way as people are learning about this area. I think today what we've learned is integration for maternal mental health is very possible. It takes time and a great deal of advocacy when we need to work alongside our very busy colleagues. And we have found creative ways in different contexts to support health workers to be able to identify mental health conditions and then get people access to the support that they need. So for me, this always becomes a question of what's the most effective way to integrate? Is it putting that psychologist into the hospital? Is it building the capacity of general health workers to really be able to identify and support and manage mental health? I think there's just different ways to do it in different contexts. So thank you very much to you both. And I know we've had a few questions about will the slides be available or the recording be available afterwards? So I wonder if Joy might still be online to let us know if people could access the information from this webinar after today. But otherwise, thank you very much, everyone.
Yes, I can confirm that we will share the recording after this session and it will be available on the MHIN website and the Special Initiative for Mental Health page. So thank you. Over to you, Aisha.
Brilliant. Thank you so much, Joy. And just thanks to all of you as well. I've been seeing your comments come up in the chat. It's very rapidly learning about what you're all doing in your context, what challenges you're facing. I just saw someone saying psychologists aren't recognized as part of the workforce in their context. You know, these are the challenges that we're collectively facing together. And it's, for me, very nice to be joining you all on this webinar today, to be learning from what our colleagues are doing, but also learning from all of you as the audience on the work that you're doing too. So thanks very much, and I wish you a good rest of your day. Take care, everyone.